you're there.
Hello and welcome to the weekly health webinar brought to you by JKYog and Radhakrishna Temple of Dallas. Food allergies. Chances are you either have it yourself or know someone who does. Food allergy is an immune system reaction that occurs soon after eating a certain food. It is a serious and potentially life-threatening medical condition affecting 32 million Americans. However, food allergies are often misunderstood. To dispel these food myths and misconceptions, we have with us today allergy and immunology specialist Dr. Sonak Daulat. Dr. Daulat specializes in treating children and adults with allergies, asthma, and immune issues. One of his main areas of focus relates to desensitizing patients who have seasonal and food allergies, and he will be talking with us about that today. Dr. Daulat started his private medical practice in 2001 and has offices in East Dallas, Bela Downtown, and Sunnyvale areas. He is a native Dallasite and he attended medical school at Boston University in Boston, Massachusetts, after which he completed his residency and specialty training in allergy immunology at UT Southwestern Medical Center in Dallas. Away from work, he teaches medical students at UT Southwestern and enjoys spending time with his family, traveling, and biking. We will have a brief Q&A after the presentation. So if you have any questions relating to today's topic, do go ahead and submit your questions in the chat window, and time permitting, we will get to it. With that, I am delighted to welcome Dr. Daulat. Dr. Daulat, thank you for joining us today. Over to you.
Ragini, thank you so much for that introduction, and good evening to everybody. I hope everybody's doing well. First of all, I want to start off by thanking Dr. Kanti Agarwal and Dr. Kandalwal for inviting me to speak to you all today. I'm sorry that we're not able to meet in person, but at least we are able to discuss an important topic that I think all of you probably either deal with yourselves or know somebody that has this issue with food reactions. You know, as an allergist, we see food allergy all the time. We see patients coming in frequently complaining about some sort of food allergy, or that their medical ailment, whether it's arthritis or headaches, could it be from a food allergy? It's probably one of the most common questions I get asked. And I think one of the reasons for this is because if you think about it, we eat every day, all day, throughout the day, every 3-4 hours, we're putting something in our mouth. And so if you do the math, it adds up to about 1 to 2 tons of food per year that we are consuming. That's a lot of food. And it's a lot of protein and vitamins and minerals that our body has to handle and process. And of course, the GI tract is what does this. And the GI tract, believe it or not, is 30 feet in length. So in our stomach area, we have 30 feet of GI tract. And in fact, if you that GI tract out, it would be the width of a tennis court, which is about 30 feet in length. So that's a lot of surface area that the GI tract has to handle and be able to differentiate between nutritious stuff like food and toxins and infections. And sometimes the immune system, which really controls and, if you will, protects the GI tract, starts to attack things that it shouldn't. And that's what causes an allergic reaction. And that's really going to be the focus of our talk today. You know, just to give you some statistics, there are 100,000 ER visits per year due to food reactions. There are 3,000 hospitalizations and about 100 deaths per year. This is just in the US. So it gives you an idea that this is a very serious disease, and one that is often unfortunately brushed aside by people who don't have it or you know, have very mild issues with it. But so what we'll do is, and I realize it's a Friday night and it's 8 p.m., so we'll try to keep this as interesting as we can so we're not putting people to sleep. So what we're going to do is we'll discuss just sort of a broad overview of the food reactions that one can see. We'll talk about why food allergies occur, how common they are, what are things that you can do to try and prevent food allergies, and then treatment, which of course is very important, especially in patients that are dealing with this. So first of all, I thought we'd start off with facts or myths. So these next two slides are basically common things that you're going to hear out there that you may have, heard about. And what I want each of you to think about is, are these facts or are they myths? So is there truth? Is this true or is it false? So I'm just going to read them for now, and then at the end of the discussion, we'll come back to these facts or myths. The first is, if you're allergic to seafood, then you cannot get contrast dye. The only way to outgrow a food allergy is to eat the food. Children never outgrow their food allergies. If you are allergic to peanut, even smelling it may cause you to get sick. If you think you are allergic to a food, stop eating it completely. Benadryl is the first line of treatment for anaphylaxis to a food. By anaphylaxis, we'll get into this, but this is a very serious allergic reaction that one can have to a food. Peanuts should be banned from airlines and schools for safety reasons. If a product says may contain that allergen which you are allergic to, you should completely avoid it. So again, a little quiz, facts or myths, and then when we come back at the end, we'll go through these. So broadly speaking, any type of a reaction that you have to a food is split up into two types. One is a food intolerance and the other is a food allergy. And food intolerance includes toxic, metabolic, pharmacologic, and idiopathic. And by definition, a food intolerance is not immune mediated. And this is a really important point, as we'll see, because with food allergy, it is immune mediated, but with a food intolerance, it is not. And believe it or not, a lot of people that think they have a food allergy actually fall into a food intolerance. And food intolerance, typically patients can present with a variety of symptoms. They can have, of course, GI symptoms, but they can have neurologic symptoms. They can have symptoms of their skin, and muscular stuff. So it can be quite broad respiratory symptoms as well. And again, it's broken up into four major types. The first is toxic. So a toxic thing is probably something all of you at some point have had, where you've had food poisoning, you've eaten a food that was spoiled and got sick, either a bacterial or viral process was occurring. Another one that we see is something called scromboid fish poisoning. And I bring this one up because it often presents just like a normal food allergy. But in this case, it's due to spoiled fish. So the fish actually, if left out, will produce histamine due to certain bacteria in the fish, and that causes this scromboid fish poisoning. The typical history is that the whole group that had that fish would have gotten sick, versus somebody with a fish allergy, typically it'll just be the one person. So that's usually how we differentiate this type of food poisoning from, say, a fish allergy. The next type is a metabolic, and this is very common, and the most common example is a lactose intolerance. We especially see this in Asians. 70 to 90% of Asian adults have a lactose intolerance. What is that? It's the inability to digest lactose due to a lactase deficiency. Lactose is the sugar that's found in milk and other dairy products. And so patients will come in saying, well, I have dairy, I have ice cream, or I have cheese, and my stomach gets upset, or I get diarrhea. I think I'm allergic to the food. Well, they're actually not allergic. They have, by definition, a food intolerance due to this lactose intolerance. And there is treatment for this. There are lactase tablets that are pretty easily available. The next one is pharmacologic, and this is sort of self-explanatory. Pharmacologic includes caffeine, alcohol, tryptamine. These are things that we may ingest that will cause obvious effects, like caffeine, for example. We all have that morning cup of coffee to wake us up, but caffeine can increase heart rate and can cause jitters and these things. Alcohol, we know about the sedative effects of alcohol. Tryptamine is the amino acid that is found in turkey and tofu and in certain nuts. And it causes basically that sort of sedation. They talk about that Thanksgiving somnolence, that sleepiness we get after a big Thanksgiving meal is probably due to the tryptamine in the food. Then there's this category of idiopathic, which is we don't know the exact mechanism, but it's well described. Examples of this include sulfites, which is a preservative found in wines. For example, MSG, which stands for monosodium glutamate. This is a common additive that they use in flavoring of food to enhance the taste of it. And some people do get sick from it and can develop headaches and flushing and these things. And then gustatory rhinitis is an interesting one, also commonly seen in Asians because of, I think because we tend to eat more spicy foods. Gustatory rhinitis, basically, patients will come in, they say they'll have something spicy or like a real pungent, strong tasting food, and will have a runny nose. And it's really a nerve thing that's occurring within the sinuses, and like I said, is commonly seen in Asians. All right, let's see. I am not able to progress my slides here.
Pooja ji?
Let's see here. Pooja ji, are you there?
Let me call her, Dr. Dolat.
Okay. Sorry, we'll see if we can get this AV issue resolved. Let's see. Let's see.
Radhe Radhe, I think Dr. Dolat just dropped off the call. Please, we request your patience. He will be back soon. Thank you. We are having some technical issues. We should be able to have Dr. Dolat back on.
So while we wait for Dr. Sonat to join us back, he must be just having some internet problems. We have Mahashivratri celebration going on at the Radha Krishna temple right now. It's a 1 week long celebration from Friday today to Thursday next week. Like to share a little flyer with you all with all the activities. So starting from today, every day from 6 to 8 o'clock, we have beautiful devotional chanting. On Thursday, we do have the Maha Abhishek for our Gopishwar Mahadev at the Radha Krishna temple. Invite all of you to join us, perform the Abhishek. Either you can come to the temple or you can also participate online through Zoom. Do look out for the information on radhakrishnattemple.net website, and you will receive all that information. Tomorrow, on this nice occasion of Shivratri, we will be releasing a brand new kirtan, a bhajan on JKYog Music. And that is going to be absolutely fantastic. We have a little teaser, a little promo. We will like to play that.
Tell me when.
Yes.
Yeah. Okay. So sorry for the AV technical issues here. one of the challenges of doing these types of meetings, but thank you for your patience. So we'll continue on and move on to the definition of a food allergy. So we discussed food intolerance and we discussed different types of food intolerances. Now we'll talk about food allergy and specifically define it, because I think it's important for everybody to have an understanding of what a food allergy is. So by definition, a food allergy is an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. And this is a definition that is defined by the NIH. Now, there's various types of food allergies. As you see here, IgE, food protein-induced enterocolitis syndrome, eosinophilic esophagitis, Heiner's syndrome, and celiac disease are some of the immune types of reactions that we see under this umbrella of food allergy. So it's in and of itself, food allergy can be quite broad. Things like eosinophilic esophagitis are quite common. We see quite a bit of this in an allergy practice. But today we're going to focus on a very specific type of food allergy. That's the IgE anaphylaxis, red meat, food-dependent exercise, oral allergy. These are the types of reactions that we're going to focus on today. And so just a little quick primer on immunology. We won't get too technical here, but I think it's important just to have a basic understanding of the immunology here. So the IgE antibody here that is the main antibody that produces the reactions, the allergic reactions. And the IgE antibodies sit on these mast cells and wait for a food protein, which is diagrammed right here, to enter our GI tract and then release the chemicals that cause the reaction. Now, the food antigen can be any food, and it's usually a protein, but it could be anything. It could be a seed, it could be a peanut. As we'll see, the most common foods are actually egg, milk, wheat, soy, peanuts, and fish and shellfish. Those are the most common ones. But remember, our immune system and body can react and develop an immune reaction to just about any food protein. But again, the IgE antibody is the important antibody that we all have these antibodies, but unfortunately, in some of us, those IgE antibodies are producing reactions to things that they shouldn't be. So by definition, again, food allergies IgE mediated. Mast cells are the main cells involved in the reaction. The reaction tends to be quick, and this is an important thing that when we get a history of patients that come in with a potential food allergy, is we want to know how quickly is the reaction occurring. If they eat a food and the reaction occurs a day later, it's not a food allergy. Usually food allergies are going to occur within 30 to 90 minutes of ingestion. And the typical reaction will be hives, which are these kind of red whelps on the skin, shortness of breath, vomiting, and sometimes in severe cases can lead to hypotension, drops in blood pressure, and even death. And again, we talked about the common foods. I've listed those here. Now, so why do some people go on to develop IgE antibodies to these foods, whereas the majority of us do not have this issue? It's really a breakdown in the immune system. In a way, the immune system has gotten bored and is reacting to things that it shouldn't, which is then causing this sort of reaction. And we have testing that we do to try to confirm that in a patient that comes in with a convincing history. And this shows a patient getting allergy tested. So we prick the skin and then we measure what's called the wheal and flare. So an allergen is dropped, the skin is pricked, and then we measure reactions. And here at the bottom, you can see some of these pretty strong reactions. Each of these numbers corresponds to a different allergen or a different food. And by the skin testing, we can then tell patients what food they need to avoid. So what are some risk factors for developing food allergy? And there's a list here. We'll run through this because I think each of these are important. The first is being a male. So being a male, especially a boy, is a risk factor for developing food allergies. It's more common in boys than in girls. Race plays a factor. African Americans and Hispanics have more food allergies. And until recently, we didn't know this, but even Asians, especially Asian immigrants, have a much higher incidence of food allergy than Americans, say, that have been here for multiple generations. Antibiotic overuse, this has to do probably with the change of bacteria that occurs because of overuse of antibiotics, which we have been doing a lot of, especially in developed countries. Genetics definitely plays a role in food allergy. And this is something that's a growing area of research. Having other allergies, having sinus allergies, having asthma, having skin eczema is also a risk factor for having food allergy. Low vitamin D levels. This is an interesting one because vitamin D we all think about for our bones and calcium, but vitamin D actually plays a much bigger role in our immune system in regulating it, and low vitamin D levels may be predisposing us to food allergy. Our diet, what we eat, definitely makes a difference. If you're eating a diet low in antioxidants and low in omega-3 polyunsaturated fats, which is basically more of a plant-based diet. So if you're having more canned foods and processed foods and these things, that's a risk factor for developing food allergy. Obesity, we believe obesity is a risk factor because it creates inflammation within the body, which then predisposes one to developing these abnormal antibodies. The delay in introduction of foods to young children, we'll talk about this later in the talk, but that is a risk factor. And then this is really a hot topic in our world. It's called the hygiene hypothesis. Are we too clean? And this has to do with sanitation, a little bit with antibiotic overuse, and just not getting the infections that we used to get. And as a result of that, the immune system may be getting bored, causing food allergy. And if you look at, for example, first world countries like the US and Canada and Australia, there's definitely more food allergy there compared to third world countries in Africa and in Eastern Europe and those areas. So that's why this hygiene hypothesis is a real hot topic and has been for many years discussed as a cause. I would tell you it's probably multiple factors involved in the rise in food allergies. Hygiene is just one of the important ones to remember. So what about alcohol and NSAIDs? So basically, in a nutshell, those create what's called a leaky gut. So it makes your gut more open, and that means that you may be absorbing more protein and therefore predisposing yourself to getting a food allergy. All right, so how common is food allergy? So worldwide, about 5% of adults and 8% of kids have it. A lot of these prevalence studies do come from first world countries. So it's probably in the US close to about 10% of kids have a food allergy, and about 5 to 8% of adults. Peanut allergy alone is 1 to 2% of the US. So the entire US population, the number is probably closer to 2% have a peanut allergy, and that's definitely a growing number. And this shows in a diagram, and I like this one because it sort of shows what we were discussing earlier. If you look at, again, here we are in the US and Canada, the darker red and oranges are where food allergy is more common. So you can see this here, and then in Australia, and then the other parts of the world, not as much. And so this is where we are thinking of things like hygiene hypothesis to explain the prevalence difference. All right, so racial differences. We talked about Hispanics and African Americans having a higher incidence of food allergy. What about Asians? And I know a lot of us on the conference today are of Asian background. So it turns out that Asian immigrants, 10% of those kids have a food allergy. And again, this is very recent data. The study came out of Stanford, and they looked at specifically mostly Asians coming from the Indian subcontinent, and found that about 10% of those kids had a food allergy. And what's astonishing is that most of the parents and the grandparents of those kids did not have a food allergy. And so it is definitely a rising concern, and one that's been seen in other studies too. There's an Australian study that looked at Asians and specifically Indians migrating to Australia and found a higher incidence of allergy in those kids as well. And then there's been studies in other immigrants. For example, Israeli immigrants to England had a higher incidence of allergy. Their kids did. And so there's probably something to do with being an immigrant to a new country that may be predisposing those kids to more food allergy. And in those Asians, the most common foods were tree nuts. So like walnuts and pecans and pistachios and those. And then other thing that was unique to the Asian population was lentils and chickpeas were much more common. About 12 to 13% of those patients, of those kids had a lentil and chickpea allergy. That's probably because, you know, we eat more in our diet. We eat more of this in our diets. It's not, you know, it wouldn't be unusual to think that there would be more food allergy to those specific foods. Okay, so let's say you have a food allergy. What can you do to lower your risk of food allergy? Or more importantly, let's say you want to prevent food allergy. So the first thing is eating home-cooked meals. So by that, what I mean is, let's say you are from the Indian subcontinent, and you're and so eating, you know, naan and sabjis and dals and those things are probably going to be a lot healthier for your immune system than eating BK Whoppers and McDonald's and French fries and those things. So eating your home-cooked khana that you have been, that your ancestors have eaten seems to be protective. Weight control and exercise, of course, are important for any chronic disease, but included in that is food allergy. Spending time outdoors, and this may be due to increasing in vitamin D levels. Introduction of foods at an earlier age. And we talked about this briefly about risk factors. So introducing the child to foods, especially solid foods, around that 4 to 6 month mark is very important. There was a trial, it was called the LEAP trial that showed this. And it was an important trial, looked at peanuts, but it turns out that all solids should really be introduced at an earlier age and not delayed. Having said that, though, it is important, if possible, to breastfeed till about 4 to 6 months of age, and ideally exclusively. And I know this is easier said than done, but studies have shown that that is protective for food allergy. All right, what about treatment? So if you have a food allergy, what do you do? Well, avoidance is key, and of course, this is difficult because as we were talking when we first started our meeting here, is that we eat all day long. We go to restaurants. Kids go to camps and school. So it can be difficult to avoid the food, but that is important and that's key. Teaching, we do spend a lot of time teaching patients how to read labels and how to look for specific items and things they may be eating so that they don't get sick. Limiting the use of NSAIDs. Again, NSAIDs are things like Motrin and Aleve and naproxen and aspirin. Antacids and alcohol. Now, again, these things make the gut more leaky, which can, if you have a food allergy, can increase absorption of that food, and then you have a more severe reaction. Learning to read labels. So we do send patients to nutritionists where they can learn how to navigate through figuring out what foods they can and cannot eat. In the U.S., we have something called the Food Allergen Labeling and Consumer Protection Act of 2004. This is an important one that came out in 2004 that mandates that all manufacturers of foods have to list the main food allergens on their packaging. So if it has egg, milk, wheat, soy, peanut, or shellfish, it must list that in bold. So if any of you have gone shopping and you go look at bread or you buy a box of crackers or something, on the labeling of the ingredients, it will put it in bold, contains wheat or contains milk. Now, of course, if you have a food allergy to something like, say, sesame seed or something that's not as common, that will not be in bold. So it can then get a little more tricky. We're eating out in restaurants. So this is an important one as well. And, we all like to eat out. We probably have all been eating out less because of COVID, but when we do go back to resuming normal life and you go into restaurants, it's important that what we tell our patients is it's important to let your server know that you have a food allergy. Believe it or not, 50% of people that had a reaction in a restaurant, the 50% of them never told the server that they had a food allergy. And so it's important to let your server know. You probably also want to call ahead and just to see what kind of options they have, especially if you have a food allergy that's pretty common. May contain traces. And so this is a question that we get asked quite often. What if the labeling on the cereal box says may contain peanuts or may contain milk? Can I have that if I have the allergy to it? And in most cases you can. So the reaction rate there is very, very low. It's somewhere around 1% or less. So we typically tell patients that if it says may contain traces, that you're okay to actually consume the food. Epi-pens and adrenaline. So this is critical and should be the first line of treatment for a patient that has a food allergy. Too often we hear patients getting Benadryl as a first line of treatment, and that is something that we really educate patients about, not to use Benadryl. So, and I should probably rephrase that. You can use Benadryl, but your first line of treatment should be an Epi-pen or any form of adrenaline. It doesn't have to be the branded Epi-pen, but some sort of adrenaline should be your first line of treatment. Then Benadryl can be given secondary. And then this is an exciting new area for us as allergists, which is this oral immunotherapy treatment. Specifically, the drug, it's not really a drug, but the compound is called Palforzia. And it does offer patients a potential, I use the word cure loosely, but it does allow patients to consume peanuts, and it basically desensitizes them to the food. And this is a really growing area in the world of food allergy. And I would say in the next 5 to 10 years, we're going to have a lot more foods available that we're going to be able to desensitize patients to in the clinic. And so this shows a girl getting the Epi-pen, and this is a trainer, so she's not really injecting herself, but this is a trainer, and we do train patients, and it's important that if you have a food allergy or you have your child that has a food allergy, that you are comfortable using it if you had to use it, and use the trainer. Ideally, the ideal spot is to inject into the lateral part of the thigh. And then you just sort of hold it just like she's holding it, and you can sort of slam it into the thigh muscle there. You want to hold it for 10 seconds, and then you release the needle out, and then you dispose of it. And it can go through clothing. You can put it through jeans or through your pant. You don't need to. So if you're in a public place, let's say you're in a restaurant and you have a food reaction, you can inject that straight through your clothes. That's not a problem. Let's touch a little bit about peanuts, because peanuts get such a lot of media press. It gets a lot of press, and I think some of it is the media. They tend to sort of catch on to these things because it can be dramatic. Because milk and egg and these things are also equally as important allergens. But I do want to spend a little bit of time on peanuts just because it gets so much. Media attention. We have seen a dramatic increase in peanut allergy, but all food allergies, we've seen a dramatic increase. So peanut alone, in 1997, about 0.4% of the U.S. had a peanut allergy, and then you can see that's steadily gone up. And in 2020, it's probably closer to 2% of the population has a peanut allergy. One of the reasons we think that there's such a higher incidence of peanut allergy in the U.S. compared to, say, a country like China, and actually in China they consume more peanuts than we do here in the U.S. And one of the reasons why we think that is because we boil the peanuts here versus they roast it. We roast peanuts in the U.S. and in China they boil it. We think that may be the risk factor. It turns out roasting peanuts increases the allergenicity. It makes the peanut more allergic. And so this is, and actually the history behind that is an interesting thing. So I'll just spend a little bit of time discussing this. I'm sure all of you have heard of Planters Peanuts, and it was founded by a gentleman named Amedeo Obici. He was actually an Italian immigrant, and you talk about the American dream. He lived it. He came in 1906 to the U.S. He was a poor child, poor kid, didn't have much money, and his first job was actually in a fruit store where he was selling fruits and peanuts outside the fruit store. And the fruit store owner had a roaster, and the peanut were roasted in order to attract customers into the store. Well, Mr. Obici took this idea, founded his own company, and all his peanuts, of course, are roasted because that's how he started when he was a young boy. And of course, he founded an international multi-million-dollar company in Planters. And then this is a picture of Mr. Obici here. And just a little bit of history. This is, I'm sure all of you have seen at some point this Mr. Peanut, right? He's famous. And so this was actually made by this boy, Antonio. He was a young schoolboy. He was like 15 or 16 years old. And he entered in a contest that Planters had to come up with a logo. He won $5 for coming up with this logo. It's just an interesting logo. And I bring up the logo because many of you, well, some of you, this happened right as COVID hit, so I think a lot of people missed this, but Planters had this commercial right before the Super Bowl in 2020 where it actually killed Mr. Peanut. So Mr. Peanut actually died trying to save his friends. And it was just a marketing ploy by Planters, in terms of them trying to market stuff and do media stuff around the Super Bowl. But it does bring up the question, with peanut allergy, has jelly lost its partner? Because there's been a growing trend in the media and in chat sites and stuff that we should be banning peanuts from public places, like for example in restaurants and in schools and in airplanes. And so at times there's been this threat that maybe peanuts may be difficult to get, but that's unfortunately or fortunately that's not the case. Peanut allergy is obviously a very serious condition, but it turns out that eliminating it from public places is probably not helpful. And in fact, studies have shown, there's some studies that were done in Massachusetts in public schools there, where they basically banned peanuts in their schools, and actually found that those kids were having more reactions than in schools where they were allowing peanuts. The thinking is that the kids were just carefree and they weren't paying attention, and somebody was accidentally bringing in peanuts in from home into the school, and they were having a lot more reactions. So bottom line is there's probably better ways of keeping people safe rather than banning them, because studies so far have not shown that to be the case. But I do want to bring up an important point that those who have this food allergy, it is very scary to them. And the best example I can give you is it's kind of like walking in a land of mines. That's the analogy that I give patients and their families, especially family members that perhaps don't appreciate the seriousness of it. It's like walking on a land of mines where you never know if that next step you might get seriously injured. And for these patients that are allergic to foods, that's what it's like. So every time they go out to eat, every time they go to a friend's house and they're eating something, they're scared that they may eat something that may make them very sick and could even kill them. So just imagine for a second having that fear every day, all day, everywhere you go, because we eat all day, right? We eat everywhere we go, we're snacking. So I think this outcry for banning peanuts, I can understand the frustration for those that are dealing with this. And you can see, if you imagine what it may feel like, why this discussion has occurred. All right, let's see here. Pujaji, are you able to advance me from here?
Yes, absolutely.
Okay. as she gets up the slides, and I apologize again for the AV technical issues, but if she pulls up the slides, you know, the quality of life, they've done studies in children, the quality of life in children with peanut allergy, if, for example, or really any food allergy, is worse than those with diabetes, rheumatoid arthritis, and even severe chronic back pain. So the quality of life of these patients can be severely affected. And you know, I mentioned that it's not just peanuts. If you look at milk, for example, milk and egg allergy is even more difficult to avoid than peanuts because it is so common and in so many different food items. Are we able to advance to the next slide? I'm gonna, we'll keep talking, and as the slide comes up, we'll go through it. So the next topic I want to talk about was how much reaction, or how much peanut does it take to have a reaction? And it turns out that as little as 1/10,000th of a peanut, patients can have a reaction to. And that's a very small amount. And at 1/10th of a peanut, you will see objective evidence of a reaction. By that I mean hives, vomiting, and shortness of breath and these things. So it doesn't take a lot of allergen for these patients to get sick. What about peanut oils? And this is a common question that I get asked. Highly refined peanut oils, those appear safe, but if you look at unrefined oils, cold pressed, expelled, or gourmet oils, those should be avoided because there is a risk of peanut allergen being in there. But if it's highly refined, those peanut oils are generally safe. The other important thing in terms of guideline is when to feed somebody peanuts and other allergenic foods. Again, we talked about this. The best thing is at an earlier age. Remember, you don't want to feed them whole nuts, but you can certainly feed them peanut flour or peanut butter starting around 6 months of age, assuming, again, that they haven't been allergic or had any reactions to them. And again, if you're allergic to the food, then avoidance, you know, is going to be important. Let's see here. I think the next thing I wanted to go through was the food myths. So if you guys remember, I first put up those facts or myths. So it turns out that all of those facts or myths we read off were all myths. So they were all untrue. And I'm going to read them out loud since the slide's not up, and then we'll talk about them briefly. And then if there's more questions about them, we can discuss them in the Q&A. The first is, if you are allergic to seafood, then you cannot get contrast dye. And this is just not true. And it is a common question that comes up. It turns out that if you are allergic to seafood, you have no issues with dye or contrast or iodine. And same goes the other way. If you have a dye allergy, an iodine allergy, seafood allergy is not an issue. Seafood is not an issue for you. The second myth, the only way to outgrow a food allergy is to eat the food. So that is absolutely not true. Once allergic, you should strictly avoid the food. Eating it will only make it worse. The next myth, children never outgrow their food allergies. Well, it turns out that's not true. Milk and egg, the majority of kids do outgrow this. Peanut is the one that tends to be lifelong. Only about 20% of people outgrow that. But milk and egg, usually by about 5 or 6, and definitely by early adolescence, the majority of kids do outgrow milk and egg. So that's important to remember. If you're allergic to peanut, even smelling it may cause you to get sick. So that is another myth, not a fact. It's false. And as we spoke earlier, peanuts have gotten a lot of bad press, you know, about banning it and so forth. But it turns out that smelling it, even just touching it, will not get you sick. It's really ingestion of it. Having said that, there are some foods that, if you smell, can get you sick if you're allergic to it. The classic one is fish. So if you are fish allergic and someone's cooking fish and you're in a closed area, you can get sick. but not from peanuts. Smelling it, that is. But you know, if you go on an airlines or something and you're peanut allergic, I think the best thing to do would be to wipe down the surface area, like the table trays and those things, because there can sometimes be residual peanut, especially if you have a young child that might be putting their hands in their mouth. The next myth is if you think you're allergic to a food, stop eating it completely. Well, no. If you think you're allergic to something, I would suggest go see the doctor, go see your primary care doctor, or visit with an allergist, get tested, confirm that this is really true, because you may be avoiding a food that is not a food allergy. Maybe you have a food intolerance, or you have some other GI issue unrelated to a true food allergy. The next myth, Benadryl is the first line of treatment for anaphylaxis to a food. Hopefully I drove that point home. Benadryl should be really more of a second line of treatment. First line should be an Epi-pen. So if you're having a reaction to a food, the first thing you should be giving is an Epi-pen and not Benadryl. And I mean, we even drive this home into the ER, and ER doctors as well. We try to enforce to them as well, give adrenaline, and have patients leave with an Epi-pen or an adrenaline when they leave the emergency room. Let's see, all peanuts, the next minute, all peanuts should be banned from airlines and schools for safety reasons. So as we discussed earlier on this has not been shown to be effective and is likely not a solution in most scenarios. The next myth, for products that may contain that allergen which you are allergic to, you should completely avoid it. We talked about this briefly. This is not necessary. For most allergic patients, the risk of reaction is 1% or less. So we do not need to be concerned generally for that. There are some patients that are exquisitely sensitive to even trace amounts. We then tell them to avoid it if it says may contain, but generally those foods are safe. And I think those are the end of the myths and really the end of my talk. And I thank you all for your attention. Hopefully, left you with some further knowledge of this very important field, and giving you a broad overview of the types of food reactions that one can have, and the importance of food allergy in terms of patients that are dealing with this very serious condition. With that, I'm happy to take questions, and I'll refer it back to and Ragini G, if they're there.
Thank you, Dr. Daulat. That was an insightful presentation and indeed very helpful. We just have enough time for just a few questions. Can food allergies develop later in life?
Yeah, that's a great question. So can food allergies develop later in life? Absolutely. So really any allergic condition can develop at any point in life. They are definitely more common in occurrence in childhood, but we see patients coming in all the time with a new onset, especially things like fish and shellfish, which is the most common food allergy in adults. In kids, the most common one is peanut. But the short answer to that question is yes, you can develop food allergy at any age.
Okay, so when it comes to testing for food allergies, what in your opinion is the most accurate, the blood test or the skin prick test?
Yeah, another good question. So, we do both. Generally, the skin prick testing tends to be more sensitive. What that means is that it tends to pick up more potential sensitivity to a food. Whereas the blood test, not as much. We can also do more testing when we do food testing. If we need to do a broad sample of foods, we're able to do that with the skin testing. Whereas with the blood test, we can do that, but it's a lot more testing, a lot more blood, and a lot more expensive. The other point is that they do complement each other. There are many situations where we do skin testing first, and then if a specific food is positive, we will do blood tests because we now have blood testing available to specific food proteins that we can draw. So for example, if we do a panel of foods and a patient's allergic to, say, milk, we can now do blood testing to figure out exactly which protein in the milk they're allergic to. So oftentimes now we sort of complement each other. But generally speaking, the skin testing is going to be more sensitive to picking up the foods than the lab testing.
Okay, so what can probiotics help with food allergies?
Yeah, that's another common question that we get asked, and the bottom line is we don't know. There is some data to show that it is helpful, but then there's some studies that show that it hasn't done anything. Here's my personal take, and what I tell my patients is probiotics are generally in capsule forms, right? And there's usually just 3 to 4, maybe 5 strains of bacteria in there. You know, in our gut, we have thousands of different strains of bacteria in our gut. And so just loading up on 3 or 4 strains may or may not be. What I tell patients is it's better to that are naturally high in probiotics, which would be things like yogurt, things like plant-based foods. Those are naturally high in good bacteria. That's probably far more important than trying to pop a pill that has 4 or 5 bacteria in it.
Okay. So I remember you mentioned this too in your talk. So there was this, in the media, there was this recent news that if food allergens are introduced in children at an early age, the chances of them getting allergies later in life would be reduced. So if you can elaborate a little bit on this.
Well, yeah. So the trial was called the LEAP trial, and it was learning early about peanut trial. And basically, they found that delaying giving the peanuts until 2 to 3 years of age, those kids had a 3-fold higher incidence of allergy to the peanut than those kids that were introduced to it early. And so it really made a major change in the recommendation from the American Academy of Pediatrics, and other international pediatric associations have all followed with recommendations to give foods at an earlier age to prevent. And as far as why, it probably has to do with getting the immune system sort of primed to these foods earlier rather than waiting. If we wait, then the immune system has not seen that food, and then may be more apt to react to it. And the other thought here is exposure. If you don't consume the food, then it turns out you may often come in contact with the food through the air, through your skin, and having contact with the food that way versus in the GI tract seems to make us more apt to become allergic to it. So that's probably the theory as to why the recommendation or why it is delaying food solids until later in age may not be beneficial.
Okay. With that, we come to the end of our session today. Dr. Daulat, thank you so much for being here and dispelling the common myths and misconceptions that surround food allergies. We really appreciate it. Thank you so much for your time. And thank you all for joining us. Hope to see you again on our next weekly health webinar. Thank you and have a great weekend.
Thank you. Good night. Okay.
Yes.
Let's see, Pooja, wait, you see me?
Yes.
Okay. Fantastic. Well, I don't know. I'm so sorry, guys. I don't know what was going on with this computer or internet. I don't know.
Pooja, are we still on YouTube?
Yes, we are.
No, on YouTube we are done, but I don't know why I still see